Bismillahirrahmanirrahim. Today we will talk about the breast cancer in pregnancy from RCOG Guideline. What is the optimal management of breast cancer diagnosed during pregnancy? Pregnancy itself doesn't appear to worsen the prognosis for women diagnosed in pregnancy compared with a non-pregnant control matched for the age and stage. However, as pregnancy-associated breast cancer occurs in a younger population who may have features that carry a higher risk of metastasis such as high-grade tumors and estrogen receptor-negative tumors, these younger women may be expected to have inferior prognosis. Regarding the diagnosis of breast cancer in pregnancy, it's written in the guideline that women presenting with a breast lump during pregnancy should be referred to a breast specialist team and any imaging or further tests should be conducted in conjunction with a multidisciplinary team. Diagnosis may be difficult in women who are pregnant or lactating. Women should have a designated key worker, usually a breast care nurse. Ultrasound is used first to assess the discrete lump, but if cancer is confirmed, mammography is necessary with fetal shielding to assess the extent of disease and the contralateral breast. Tissue diagnosis is with ultrasound-guided biopsy for histology rather than cytology, as proliferative change during pregnancy renders cytology inconclusive in many women. Histology is similar to that in age-matched non-pregnant counterparts. Now, what factors decide the treatment plan? Histological grade, receptor status, and human epidermal growth factor receptor 2, that is HER2, inform the treatment planning. Now, what are the different types of imaging studies done for staging for the metastasis in the breast cancer in pregnancy? Staging for metastasis is conducted only if there is high clinical suspicion and should comprise the chest X-ray and liver ultrasound if possible. The gadolinium-enhanced MRI is not recommended unless there is specific need for it to investigate a clinical problem. Tumor markers such as CA15-3, CEA, and CA125 are not used in the early breast cancer and may be misleading in pregnancy and are not recommended. In pregnancy, the bone scanning and pelvic X-ray computed tomography are not recommended because of the possible effect of irradiation on the fetus. In the women who are not pregnant, plain X-ray, computed tomography, and isotope bone scan are the preferred method of investigation to establish or exclude the metastasis. These methods are not appropriate in women who are pregnant, in whom chest X-ray and liver ultrasound are preferred. If there is concern about bone involvement, a plain film of the relevant area and/or magnetic resonance imaging to minimize radiation exposure to the fetus is suggested. When should we consider the termination of pregnancy? The decision to continue the pregnancy should be based on the careful discussion of the cancer prognosis, treatment, and future fertility with the woman and her partner and multidisciplinary team. In pregnancy with the breast cancer, the multidisciplinary team review outcome should be forwarded to the obstetric team and the family doctors. Surgical treatment including loco-regional clearance can be undertaken in all trimesters. Breast-conserving surgery or mastectomy can be considered based on the tumor characteristics and the breast size following multidisciplinary team discussion. Reconstruction should be delayed to avoid prolonged anesthesia and to allow optimal symmetrization of the breast after delivery. Sentinel node assessment using radioisotope scintigraphy doesn't cause significant uterine radiation, but the blue dye is not recommended as the effect upon the fetus is unknown. Now, when is sentinel node biopsy indicated? Sentinel node biopsy is indicated in the women who have a negative results from preoperative axillary ultrasound and needle biopsy. If the axilla is positive, axillary clearance is indicated. Radiotherapy is contraindicated until delivery unless it is life-saving or to preserve the organ function, for example, the spinal cord compression. If necessary, radiotherapy can be considered with fetal shielding or depending on the gestational age, early elective delivery should be discussed. Routine breast or chest wall radiotherapy can be deferred until after delivery. Systemic chemotherapy is contraindicated in the first trimester because of high rate of fetal abnormality, but is safe from the second trimester and should be offered according to the protocols defined by the risk of the breast cancer relapse and mortality. Anthracycline regimens are safe. There are fewer data on taxanes, which should be reserved for the high risk, that is, node positive or metastatic disease. Standard antiemetics, including 5-hydroxytryptamine, serotonin antagonist, and dexamethasone, should be used. Tamoxifen and trastuzumab are contraindicated in pregnancy and should not be used. Regarding the timing of the delivery of the baby, it's written in the guideline that the birth of the baby should be timed after discussion with the woman and multidisciplinary team. Most of the women can go to full term of the pregnancy and have a normal or induced delivery. If early delivery of the baby is necessary, consideration of the corticosteroid for the fetal lung maturity is appropriate. However, birth should be more than 2 to 3 weeks after the last chemotherapy session to allow maternal bone marrow recovery and to minimize the problem with the neutropenia. Regarding the lactation with the breast cancer, it's written in the guideline that women should not breastfeed when taking trastuzumab or tamoxifen, as it is unknown whether these drugs are transmitted in the breast milk or not. What are the contraceptive choices for women wishing to avoid pregnancy after treatment of the breast cancer? Non-hormonal contraceptive methods are recommended. The levonorgestrel intrauterine system, or Mirena, may reduce the risk of endometrial abnormalities during tamoxifen therapy, but further evidence is required on its efficacy in the breast cancer survivors. What advice should be given to the woman planning pregnancy following the breast cancer? Women planning a pregnancy after treatment for the breast cancer should consult their clinical oncologist, breast surgeons, and obstetricians. Women on tamoxifen are advised to stop this treatment 3 months before trying to conceive because of the long half-life of the drug, and to have any routine imaging before trying to conceive to avoid the need for imaging during pregnancy. Now, what is the impact of pregnancy on the risk of recurrence of the breast cancer? Women can be reassured that the long-term survival after breast cancer is not adversely affected by the pregnancy. Regarding the time interval before pregnancy, it's written in the guideline that advice on postponement of pregnancy should be individualized and based on the treatment needs and prognosis over time. Most of the women should wait at least 2 years after the treatment, which is when the risk of recurrence is highest. Women can be reassured concerning the risk of malformation in the children conceived after the treatment for the breast cancer. Most of the available data do not show any increase in the congenital malformations or stillbirth among the offspring of the women who have completed treatment for the breast cancer. What is the optimal management of pregnancy following treatment for the breast cancer? Pregnancy following breast cancer should be jointly supervised by obstetrician, oncologist, and the breast surgeon. Echocardiography should be performed during pregnancy in women at risk to detect the cardiomyopathy through resting left ventricular ejection fraction or echocardiography fractional shortening. What advice should be given to women wishing to breastfeed following treatment for the breast cancer? Women can be reassured that they can breastfeed from the unaffected breast. What is the effect of the breast cancer treatment on women's fertility? The effect of the treatment on fertility should be discussed with all women of reproductive age diagnosed with a breast cancer, and written information should be provided. Referral to a fertility specialist should be available. Specialist counseling should be available as well. What is the effect of adjuvant chemotherapy on fertility? Chemotherapy-induced gonadotoxicity may cause permanent amenorrhea with a complete loss of the germ cells, transient amenorrhea, menstrual irregularity, and subfertility. The degree of gonadotoxicity depends on the specific agent used, the cumulative dose administered, and the woman's age. What advice should be given to women about postponement of pregnancy after embarking on the further pregnancy? Women in their 30s desiring pregnancy may wish to discuss the value of prolonged treatment with tamoxifen and consider discontinuation after 2 to 3 years. Can fertility be preserved before treatment? Can fertility be preserved before treatment? There is a rapidly growing literature on preservation of fertility potential before chemotherapy. At present, only a minority of women of reproductive age undertake fertility preservation procedure, and there are scarcity any data on the long-term outcomes. Regarding GnRH analog, it is written in the guideline that there are insufficient level of data to support the routine use of GnRH analog for ovarian protection in estrogen receptor positive breast cancer. Regarding cryopreservation, the guideline says that ovarian stimulation for egg or embryo freezing require careful discussion in the light of unknown long-term risks. Modified stimulation regimes should be considered for the women with estrogen-sensitive breast cancer. There are insufficient data to support ovarian tissue storage for fertility preservation in the woman with a breast cancer, and this should be offered only in the context of research trial. Every breast oncology service should have a designated pathway for the prompt referral to a fertility specialist able to offer assisted conception. Service provision should not be dependent on the local in vitro fertilization funding arrangements. Now we'll talk about assisted reproduction after treatment for the breast cancer. Fertility treatment after chemotherapy is limited by loss of ovarian reserve. The stimulation aspect of in vitro fertilization carries a theoretical risk as it is hypoestrogenic state, although of shorter duration than pregnancy. So thank you so much. That was all about the breast cancer in pregnancy from the RCOG guideline. Subscribe on Obs and Gynae. Thank you so much. Allah Hafiz.